Hello and welcome to Next Steps for Seniors Conversations on Aging. I'm your host, Wendy Jones, and as you know, I have such a passion for sharing information with people as we age. And yes, we all age. And one of the biggest issues that we are going to talk about today is actually joint pain. And who doesn't have joint pain? And I don't even care how old you are, but the older, the worse usually. So we are blessed to have Dr. William C. Fox with us. He is a board-certified vascular and interventional specialist, co-founder of Texas Endovascular, and medical director of Central Houston Clinic. Hello, doctor. How are you? Thanks for being with us today.
Hey, thanks for having me.
Absolutely. You have over 25 years of experience in medicine and more than a decade of leadership at one of the most advanced outpatient practices in Texas. So we are very blessed to have you with us because I was just telling Dr. Fox just a few minutes before the program started, I have about 6 or 7 friends in the past year that have had knee surgery. And half of them are like, I wish I would have never done it. And that's why you're here today. You're here because there is another way to go. And it's not just knees, it's all joint pain, correct?
Yeah, it is. It's really exciting. So as we all know, arthritis is just one of those things that's going to happen to us. The joints kind of degrade and break down with time. Certain things can obviously exacerbate it. But for many years, the only solutions we really had were injections, physical therapy, and then ultimately going into surgery. And now we have a lot less, what we call less invasive options, meaning we're not doing surgery, we're not cutting you open, we're not doing open things in the OR. What we've realized is that, especially in the early stages of osteoarthritis, is before the joint has totally broken down and you have that bone-on-bone contact, a lot of the pain you're getting from the joint is caused by inflammation of the joint, right? And so the procedure that we do is something that's called the genicular artery embolization. Whenever you get that early arthritis, you get irritation of all these abnormal nerve endings, and that's where you get a lot of the pain in the knee. That's where when you press on it, you can feel the, certain areas where people will point and say it's tender right here.
So
and
it's
what we
the
found
actual
is
nerve, you're saying, right in that area that's causing that.
so the nerves that are supplying the area are what are causing the pain. It's not the bone itself, right? And so that's why one of the pain procedures people will do is what they call a genicular nerve ablation. So they'll actually go in and burn and kind of try to destroy the nerve that's causing the pain. It's, again, pretty invasive and doesn't work all the time.
Right.
But what we do is we treat it kind of from the source, as opposed to going and injecting the knee with a steroid to try to decrease that inflammation. We go into the arteries with a tiny catheter and we snake it right out to the arteries that are supplying that joint capsule, and we inject some medicine directly into that artery. And what it does is it does a combination of things. The medicine is actually it's an antibiotic, surprisingly.
So it's going to decrease the pain.
Correct, 100%.
Because
and so
it's all caused by inflammation.
Exactly. That's why people will do like a steroid injection into your knee. But the idea is you're just putting a Band-Aid on it because you're not treating the source of the inflammation, right? The inflammation is and so the inflammation is the abnormal growth of that joint capsule. And so by us going in and decreasing that side, the thickening, it actually helps the pain. And the initial studies, a lot of this came out of Japan. And at first they were just trying to compare it to knee injections, because knee injections last about 3 months.
Well,
right?
I was just going to say exactly.
It depends. Some people 3 to 6 months.
Right.
Yeah. And so the idea was, is it as good? And then we found out, yes, it's as good. And then they say, is it better? And so now we've got studies going out to 5 years where patient has had pain relief out to 5 years. Now they're limited studies because it's fairly new in the States, but the point is it's as good or better than a knee injection. It's repeatable. And the problem with doing the knee injections, as anybody that's had those will see, is that you can only do a certain number of them, because as they inject steroids into the knee, the steroids actually can help to cause osteoporosis and thin the bone and worsen the arthritis. That's why they'll only let you do it a few times. And so
it's interesting you say that, because I was curious why they only let you do it a few times, because I've had friends, I've gone for my 3rd one and I can't go anymore or whatever, right? I've done it for a year and a half and I'm done and now I got to go to the next step. But that's a big reason why then.
Yeah, because over time, it's all, any medicine has a potential side effect. It's not necessarily a side effect, but we know, any person that's been on steroids for, asthma or breathing problems or any other issues, they know that it can cause osteoporosis, it can cause brittle, your tendons to be more fragile and friable. I mean, they have lots of side effects. Mm-hmm. And when you inject the steroid directly into that joint, you're dealing with a joint that's arthritic, and now you're making the bone more brittle and the tendons more brittle. and it just over time causes problems.
I have a couple questions for you because, as you're talking, a couple things are coming to mind. First, is there anything we can be doing to decrease that inflammation before it even gets there? Like, does everyone just automatically get inflammation, or is it people who were runners or, catchers in a baseball team, whatever? Did you overuse it, I guess? Is that what causes it to begin with?
There's definitely overuse injuries. So people that are in really kind of extreme athletic sports can get overuse injuries, especially if you've had, ligamentous or tendon injuries over time, or if you've had fractures. That all progresses, arthritis more rapidly. But the main thing is, and this is one thing we talk about all the time, is maintenance of muscle mass, because the joint is designed as a hinge, not necessarily to bear a lot of weight. Really, if you think about it, the muscles in your legs are supposed to support your knee, right? And then the knee is supposed to act like a hinge. So it's not all the pressure just jammed down on those bones. But what's happened is people lose muscle mass, then more and more of the weight bearing goes on to the joint itself. And so, and there's the key is maintenance. One of the things is that people don't think about, and I'm guilty of this now as I'm getting close to 50, is that you keep saying, oh, I'm going to, next year I'm going to really kick it into high gear. But, it gets to a point where you can't get back to where you wanted to be, right? And and literally after the age of 30, we start losing muscle mass, and if you don't use it, you lose it, never to return. There was a study that was interesting, came out in 2016, and what they did is they did an MRI cross-section of thighs in men, and they did a 25-year-old male, and then they did a 70-year-old male, and then a 70-year-old triathlete, and they measured the amount of muscle fibers, muscle units they called them, and the 25-year-old male had 150, right? Mm-hmm. The 70-year-old male had 90. The 70-year-old triathlete had 140. And it's really striking, and because anybody should Google it and look it up, and it'll really kind of get you, because you can see the cross section, and when you see the 25-year-old and the triathlete, it's all muscle with a little bit of fatty tissue, and then when you see the 70-year-old male, it's shriveled up little muscles and fat, right? And that's what causes frailty. And that's another thing with aging, as they say, is one of the predictors of frailty and age. One of the earliest signs you can see is trying to stand up from a chair unassisted. And it's harder than you think. Sit there without pushing yourself up.
Oh, no.
And if you can't, if you can't do that at a young age, then you need to start working out, because losing that muscle mass and losing those, strength, that's when people start falling. They start getting a lot of problems, and it just, all kind of circles and goes the wrong direction.
And then you end up in this situation. And so this is why I asked you that question, because I've got seniors right now in their 80s. I have them doing the sit to stands, where you sit in a chair, stand, sit, and you've got to do as many as you can. But it's because I don't want what you're talking about right now to happen, right? You got to keep your muscles strong. And of course, for some of us, it might be too late. And then you have Dr. Fox here that can help you with that scenario. But if you're listening to the program, you are healthy, you do have good knees and hips and all those joints, keep using them, because like he said, you will lose it. And then it's going to be too late. So we're going to get into some more of the procedures that he does in the next segment. This is so critical. And one of the most important things, I think, is the anesthesiologist, that you have to go under anesthesia when you go through surgery. So we're going to talk about that in the next segment. Stay tuned. You're listening to Next Steps for Seniors, Conversations on Aging.
This is Next Steps for Seniors with your host, Wendy Jones. Each week, Wendy brings resources and information to help guide you through those next steps with elderly parents and loved ones. If you have questions or topic suggestions, you can call us at 248-651-5010.
Welcome back to Next Steps for Seniors, Conversations on Aging. We are very blessed to have Dr. William Fox with us because we don't always need a major surgery. He does quite a few minimally invasive procedures that are very beneficial to you as you age. And I'm very blessed to have him. And we've already learned a lot in the first segment. But Doctor, I want to move into the second segment on some of the other areas that you touch on. Tell us some of the other parts of the body that you're able to do this procedure with to decrease the pain and inflammation.
Sure. So all the initial research was done on knees, and so that's where everybody has the most experience. But in the last few years, we've been expanding that into other areas of arthritis and inflammation. And so it's not just arthritis, but it's active inflammation in the joint. Because with osteoarthritis in the knee, you get that inflammation from the joint capsule. But what we also found is that it's effective for patients that get golfer's elbow or tennis elbow, which is an overuse injury. Obviously,
Pickleball,
you
maybe?
get pickleball, right? Yes, exactly. Pickleball's becoming so big now, especially with people that, haven't been as active in the past, which is great. But, the weekend warrior syndrome is real. People that maybe not used to that much activity. And the problem is when you get golfer's elbow or tennis elbow or plantar fasciitis is another one that's out there. These are all overuse injuries. And the problem is it's keeping people from doing things they love. We talked in the first segment about staying active and staying busy and staying strong. And so then it really frustrates people because they get out there, they find something that's fun, right? Pickleball is more fun than running. I mean, maybe some people love to run. I don't get it. But, running on a treadmill, I'd rather be out on a pickleball court. But then if they can't do that, if they get pain, then they stop. Excuse me. They stop and then they, become sedentary again. And so we can go in and do the same thing we do for the knees, where we go into that area of inflammation where you have the active inflammation in the tendon and in the ligaments, and we inject that medicine directly there. And it does the same thing where it decreases that active inflammation and it helps that abnormal thickening of the tendon to go down and the ligaments to go down and to help with the pain. And it works great for tennis elbow, golfer's elbow, patients that have frozen shoulder, where you get, it's an overuse injury. If you're people that play tennis, that overhead, motion. And then plantar fasciitis, same idea. The plantar fascia gets thickened and inflamed. And that's one that really, I have a lot of patients that are, they're on their feet for work. We have mail carriers, we have law enforcement, all these people hairstylists, people that have to be, or even older people that, retired that want to play golf or they want to walk. It's the same idea, is that they're not able to exercise and do what they want to do. Because plantar fasciitis, the only way to really get rid of it is to completely isolate the plantar fascia in a boot and be inactive, which is not what we want. And so when we go in there and we inject that medicine directly in the plantar fascia, and it's exciting from our standpoint because we can see the inflammation when we do with the angiogram. When we inject that contrast, we see those abnormal vessels. We call it a blush. It kind of lights up. It's like this blooming, and you can see. And so you inject the medicine, you see that, or the contrast, you see that blooming, and you're like, that's the inflammation. Then you inject the medicine, and then you do a follow-up, and all that blooming is gone. And so it's you're like, you can see that where the inflammation is, you can target it, and you can know that you got it. So it's very satisfying from a visual standpoint, but it's even more satisfying when the patients, come back and say, hey, I feel a lot better.
So how quickly do they feel the results of this?
So it's different for the different joints. We say maximum 3 to 6 months to get the full benefit, but you'll notice a difference rapidly within the first couple of weeks. But it takes time for that abnormal thickening to go down. And it depends on the severity. Patients, there's a grading system for arthritis in the knee. If it's really advanced and there's a lot of that synovial overgrowth, it takes longer for that to go down. And sometimes with patients that have really advanced disease, sometimes we have to repeat it, like 10% of the time. But usually it's just the whole idea is like, hey, we got 90% of it. Let's go back and just get that last little bit if we need to, but it's rare unless it's really advanced.
Well, and I'm thinking, you're saying tennis elbow, but golfers, we have got, huge golfers all summer long.
Sure.
And then all of a sudden they're not on the course. So if they had this procedure, they still have to take a break, obviously, but they would.
Well, we tell them to take 2 weeks off.
That's it.
2 weeks off.
Really?
Yep. 2 weeks off. And then after 2 weeks, you go back, and what I tell people is, we didn't make any incision, right? So there's nothing that's going to tear. It's just, we want to give your body the full chance to heal. And so after those 2 weeks, we feel like, hey, the healing process is in, full swing. We don't want to set you back. So don't go back out and play 18 holes. But if you want to go hit a bucket of balls and take it easy and see how it feels and just listen to your body, right? Because if you start swinging and it's hurting, don't say, oh, I'm going to power through it, because you're going to cause problems.
Right.
Back off a little bit and then and go from there. So it's really, that's the great thing, is that what we're doing, and I always say this, is that as opposed to going in and cutting you open or doing something, structural, we're kind of stimulating the body to heal itself.
Right.
We're going in saying, hey, these are abnormal arteries, these are abnormal thickening of the capsule. We need to decrease that, and the only way to do that is to turn that sprinkler down, to decrease that blood supply, to allow it to kind of, clamp down your body's natural healing process to take over.
So I want to talk a little bit about how you do that. Do you have an option? Like, do you need to go under, or can you do it with sedation? Tell us a little bit about the procedure itself.
Yeah, so we do the procedures. We do them here in the office, right?
Okay.
So we have multiple locations around
In
Houston and
Texas.
Dallas.
Yeah.
In Texas, yeah, Houston and Dallas. We actually have some offices in Atlanta as well. But the idea is that you come in and we have an anesthesiologist here, right? And we do, and you'll consult with them, and then you pick how much you want to do. I mean, none of it is general anesthesia, like no breathing tube, anything crazy. But we can do as little as just local only to a little bit deeper sedation to where you'll probably fall asleep, but you're laying there breathing on your own. It's similar to having a colonoscopy or dental surgery, so it's very safe. It's we keep you as light as we can, and
Yeah.
it's up to the patient. Some patients come in, they say, I don't want anything, and we just do it with
That would be
lidocaine.
me.
Because the procedure, I mean, honestly, it takes about 30 minutes.
Yeah.
It's really fast, and so we can give you a little bit of Ativan ahead of time just to help
Right.
you relax.
Hmm.
Get a little lidocaine, pick your music, and you can just relax during the procedure.
Right. Right.
Some people are a little more nervous and they want a little bit more, and we'll give them more.
Whatever it takes. And I think the reality is people, when they think of going into an OR and having a major surgery, a knee surgery, there's fear around it. I'm just going to be honest. And as we age, it gets even harder, going under. So you wonder if there's something to what you're talking about. I think it's fantastic. I love the option. You're going to see me if I ever have issues for sure. But why not just get some sedation, half hour? I mean, you could be hitting a bucket of balls in 2 weeks. I mean, come on. The difference is enormous. These shoulder surgeries, you're out for 12 weeks minimum.
Completely
Why-
immobilized.
Yeah, why would someone not want to try this first? I mean, it seems like it's a win-win all the way around.
It's a great option. I mean, and we're always very honest with patients and kind of evaluate how severe they are, because a knee replacement is a very effective surgery. They're very safe, but it's a major surgery, and
Major.
the recovery is not easy, and they're time limited, right? Because once they're good for, they say 15 years now, but and so you have to have it replaced down the road. And so if we can prevent you from getting, not maybe ultimately you end up down there 10, 15 years down the road or whatever it is, but
But you do
if we can
one,
keep you on
right.
one time and later, or if we can, the goal is to prevent that as long as possible. And I see younger and younger people getting them done now, because what they're told is, oh, they're better now. Used to be a last resort because they only lasted up to 10 years. Now they have longer time frames, so it seems like people are more willing to do it earlier. And I'm just like, try other stuff first. And so that's the great thing is again, we do it in the office. And the great thing about that is that it's, you're in and out, usually within 3 or 4 hours total time in the office. And because it's in the office, I mean, we have our own cath lab kind of surgery center set up in the office, but we control every aspect of that, which is, the hospitals they're great for what they're for, but it's a big, huge machine, and getting in and out of there is usually difficult. You don't know who the staff. I pick all my own staff. I pick all my own anesthesiologist, and it's a lot less expensive than doing things in the hospital,
Well,
because it's an outpatient procedure.
Yeah, that was my next question. Is it covered under insurance, or is this all out of pocket? Tell me a little bit
No,
about
it's
that.
covered by Medicare, and most insurance companies, because it's a newer procedure, sometimes we get pushback, and the different plans are different, but we have a whole team of people that goes through and checks on all that stuff. And, most of our patients at this point are probably Medicare.
Right.
Obviously, we have quite a few, private insurance patients, but Medicare hasn't given us a problem. So
That's fantastic. Great news. I would love you, Dr. Fox, to share your information. What is the best way to reach you?
So they can go to our website in Texas. It's www.texaseva.com, texasendovascular.com. And that's where people can get more information about any of the procedures. And if they want to, they can sign up for a consultation or even a virtual consultation. If the patients are, I know you're not in Georgia, but patients from that South area, we have an Atlanta practice as well, which is georgiaeva.com.
Oh, okay.
That does the same thing.
So all of our friends in Florida could go to Georgia easily.
Yeah,
Yeah.
exactly.
So anywhere you're listening, really, I mean, it's worth it. The most you're going to do is get on an airplane and fly to Texas or Georgia.
Yeah, or Atlanta, right? Yeah.
At the end of the day, I mean, it's way better than the alternative. I mean, and why not give it a try? And if you've already tried all the shots, with I would say almost 50% of the people I know have, this is the next step. I appreciate you so much.
Well, thank you so much for having me. I appreciate it, and look forward to hearing more from anybody.
Absolutely. So again, Dr. William Fox, you can check out his website. I definitely feel like this is an incredible alternative. First, I want to say, please keep moving and don't give up. Keep your muscles strong. But if you get to the point where you get the arthritis, there is another answer. And it is much better than going under the knife if you can avoid that. Thank you so much for being with us. You're listening to Next Steps for Seniors, Conversations on Aging.
Thanks, guys.